So we are here for a new ISICEM podcast. Today I have the pleasure to welcome Professor Djillali Annane. Djillali, thanks for accepting.
Thank you for inviting me.
Professor Djillali Annane from Garches, Paris, France, worldwide recognized expert in the field of sepsis, which will be the topic today. So I start from the very basic. Just remind everyone what is sepsis at the end. It looks like a syndrome and we struggle sometimes with definition. What is sepsis?
Yeah, I think sepsis is, first of all, one of the major threats in the world. It is affecting so many people, about more than 160 million every year in the world. Europe is not an exception, more than 8 or 20 million each year in Europe. So first of all, sepsis is something placing a huge burden on societies around the world. Sepsis is defined as the main complication of infection. So the starting point is to have an infection, whether it's a virus, a bacteria, a parasite, or a fungi. That is the starting point. And from that starting point, many, maybe most of people will have an appropriate response to eradicate the bugs and will get back, recover, and get back to their normal life. Unfortunately, some of them, their immune response and metabolic response won't be appropriate. So it, of course, is going to eradicate the pathogens, but side effects include a deregulation of a function of the immune cells and other cells and tissues in the organism that end up to trigger dysfunction of vital organs.
Yeah.
And that may indeed result to death.
So, of course, as you mentioned, it's important. I think most intensivists will know it's much more than infection. Now, we think as intensivists that one of the big advances in the management of sepsis has been the development of guidelines, because guidelines help everyone how to treat the patients. We don't need to be criticized or criticized everything, but my question is, what do you think about the guidelines, the role of guidelines, their impact on care, and sometimes also we should say their limitations?
Yeah, guidelines are only tools to help the decision-making process. They are nothing else. So guidelines are a way to summarize for people what is currently known about the disease, its management, and its treatment. And with that summary of the knowledge, physicians at the bedside, according to their local ecosystem, to their healthcare organization, to the hospital organization, to the staffing of the intensive care unit, and will use these tools to make sure that they give the opportunity of their patients to get access to the best option of management. I think that is the way we need to use guidelines, and we should not consider guidelines, as law. Guidelines is not a law. It's not a regulation.
Yeah.
It's a tool to help the decision, the clinical decision making.
I think it's important what you say, because of course there are legal issues in some countries. Look at the guidelines, if there is a problem, or this is the law, as you said. But it's important to recognize, and I'm happy that you said this, that this is the baseline to start with, and then should be adjusted to your resources and sometimes also to the patients. Going to the guidelines, I don't want to make an entire podcast on that, is not the aim. But for example, what do you think about this story of early antibiotics? We have to do as soon as possible. Is it really the case? Many people say, if the patient is not so severe, we might wait. But some others says, as soon as you give the antibiotics, you might reduce the burden of the sepsis and then reduce the probability the patients progress to septic shock. What is your view on that topic of timing, which is really a great debate in the literature?
As I mentioned in the beginning of the podcast, is to me, sepsis starts with an infection. So you have a bug. So you need to eradicate the bug. You need to help the body to get rid of the bug. And the antibiotics are there for that purpose. So I think we have learned for the past decades that early administration of antimicrobials is really needed to help the patient, to prevent deterioration in a patient. But the problem is antibiotics alone is not sufficient
Yeah.
because speed saves life, but precision even more.
Yeah.
That means that what we need, after all, is the capacity of identifying as fast as possible the pathogen that is triggering all these immune problem and
Absolutely.
castor. So that is the challenge today. The challenge is how can we make sure that we can get the answer about what is the pathogen responsible for the infection within hours rather than within 28 hours or 72 hours like it is nowadays. That is a challenge. Precision as soon as possible.
I like this point because when I always say my colleagues, if you know this patient is infected, just give antibiotics. Don't wait 3, 4, 5 hours. Give just. And then before moving to the immune response part, I have a last question. Again, in intensive care field, for many years, we have tried to improve sepsis outcome looking at hemodynamic management because you have the antibiotics, as you said, you treat the bug, and then you have to restore, I think, within perfusion to reverse organ failure. So fluids, vasopressors, inotropes, early goal-directed therapy. Where are we now in 2026 with all these hemodynamic management or innovation or possibilities?
Well, what I can say is when I compare with the time I was a resident, now we know much better how to monitor the patients, how to build targets, hemodynamic goals, how we should guide the way we will resuscitate the patient. That is a major advance. And so we do this now less invasively. So it's more easy, more robust, more reproducible from one physician to another, which is very important because for a single patient, there are many physicians that are playing a role. So that is very important. So I think that is a major advance. And now we know that also fluid and vasopressors should be given likely in combination, in parallel, rather than one after the other.
Yeah.
I think that is an important thing. And the third message on that topic I would like to make is we now start to know that it may be much better to have multiple vasopressor rather than increasing the dose of norepinephrine up to levels that may really compromise tissues and end up with major sequels. So that multimodal approach of combining different vasopressors, I think is likely to change progressively, but surely the way we manage the patients in terms of the cardiovascular system.
I think this aspect is relevant because we discussed about antibiotics and how this should be given as soon as the sepsis is identified. Then how the hemodynamic management now is trying to target the endpoint rather than fixed doses or drugs or amount of fluid. That's really interesting. Still remaining in the guidelines, the 30 cc kilograms, but that's another story. But I would like to discuss with you something that I presume is something that you like a lot, which is the advances we have now in the understanding of the immune response. So we kill the bug, nice. We try to perfuse the organs, nice. But still we have to deal with the immune response. I don't want just to guide your response. So my question very easy is, which is the advances we have recently in the immune response, especially in the concept of phenotyping the patients with different immune response according to their signature, genomics, or transcriptomics. You will tell us where do we are now.
I think our advances are definitely driven by advances in molecular biology tools and for sure now advances in artificial intelligence. So indeed, when the concept of sears and cars began in the late 70s, it was triggered by the discovery of cytokines,
Yeah,
TNF-alpha and IL-1.
exactly.
That was the driving force for all the concept of sears and cars and so on. And thereafter, we get more easy access, thanks to all these omics tools, at a more granular level of the molecular action that are in play in the response to a pathogen. And this is what now we are starting to understand. We're starting to understand that each individual is mounting a different response in terms of the immune system, and a single individual may mount a different response according to a pathogen that is invading the patient. So that is something that we have now recognizing, and we have tools that are more and more accessible at the bedside or at least nearby the patient that will help doing what you have called the subphenotyping. So subphenotyping simply means that we will be able to say, okay, that patient, most of it, most of the severity of illness is driven by TNF alpha or is
Exactly.
driven by interferon gamma, and then we identify a causal mechanism, and we may be more likely to manipulate that causal mechanism to get the patients back to homeostasis. And I think that is really very important. And what I think is going to be the game changer is the implementation of AI in this game, because AI will for sure accelerate the understanding of the interplay in between the different pathways that happen at the molecular level in a far better way than any human can do, and will be able to democratize, if I may say, this molecular description of single individual in every hospitals.
Yeah,
Large academic hospitals, but also other
absolutely.
hospitals, because AI, as we know, is really now being implemented everywhere.
Everywhere, yes. I think that many people, maybe as an intensivist, have not recognized the interest of this immune response, probably because all, I would say not recent, but many of these initial studies looking at immune response gave us, as you said, a subphenotype, but then what you do with this subphenotype. I mean, okay, it's nice to know that you are hyper-inflammatory. This was the ancient definition, but what I do with this? Now, I would like to maybe to remind everyone that, for example, there are some subphenotype like macrophages activation syndrome, as you said, the interferon gamma-driven immunoparalysis. Maybe you want to say word of netosis, because I know that we have a common interest in this. Which are the clinical implication? Because now we have a phenotype, probably, don't want to be too clear on that, too straightforward, but we can do something on those phenotypes. Can you remind to our listeners what we can do?
Yeah, I think that I would answer this by pointing out that to me there are two different situations. There are phenotypes that are defined by a molecular target for which we already have drugs that we
Available.
know are available and efficient in modulating that target. And for example, when a patient gets high ferritin levels, highlighting the likelihood of having macrophage activation like syndrome, we know that drugs like anakinra are able to deal with that problem. And likewise, if we had patients in whom soluble TREM is driven the problem, we know we have monoclonal antibodies that also can help modulating in the good way that target. And you were talking about netosis. So netosis is not a new field. It's
No.
known for a while. As usual, the cancer people have investigated that field far before we do. But I think, to me, netosis might be a very important treatable threat to select the patients in whom the neutrophils activation is the driver of the organ failure and organ dysfunction. And that is potentially important because we know we can target netosis. Excess of netosis, there are drugs that can accelerate the clearance. There are also extracorporeal device with absorption colon that can help removing the nets. So it's a molecular biomarker for which we have already interventions available. So we need to operationalize this, and we need to figure out how we can bring at the bedside on the other patient the assessment of how much netosis the patient has at time X, and to decide if we treat.
Going at this, maybe one of my last question on the immune part. Do you think that having this phenotype, for example, of macrophages activation syndrome versus immunoparalysis, is it possible that the same patient might go through different immune response over time? So maybe if you treat at the beginning, that response might be effective because this is the main phenotype, but some patients might evolve over time. So we might have different immune response in the same patients, which even furthermore complexify the immune story in sepsis.
Yeah, and again, it's really not surprising because who can believe that our body remains passive? Say, okay, now I'm admitted in the ICU, the ICU physicians are taking care of me, so I have no more things to do. No, the body is still continuing the response, and the body knows better than we know how to deal with the problem. So this is a dynamic process. The host response is not static.
Yeah.
It progresses over time. Of course, it can be modified by interventions we are giving to the patient. Some of these interventions we give them for patient to target the immune system. Other, we use them for something else, forgetting that intervention might be able to influence the immune response.
Yeah,
Some of the antibiotics, for example, that are widely used in these
Absolutely.
patients. Or we know also that sedative drugs, some of them, like opioid and opioid-derived, may interfere with. And of course, if the patient is receiving extracorporeal circulation for kidney, for the liver, or as a cardiovascular system, likewise.
exactly.
So we have to consider all of this, and I don't think this is achievable by human being. So here again, artificial intelligence is really, and we are working. I'm now heading the Comprehensive Sepsis Center, the Prometheus EHU Center in Paris, and we are trying to develop digital twin. So the idea is, of course, that we leverage on artificial intelligence to
Absolutely.
be able to
Fantastic.
to be able to really dissect angle for individual patient at individual time and in a continuous manner what is the actual host response, what are the effects on that response of the different interventions of the pathogen, and some of our patients, unfortunately, they get secondary infection.
Yeah.
So that's a new heat, and how the host is responding to the heat, how this is interfering with the initial sepsis. All these, I think, will be much easier solved with the help of digital twin and artificial intelligence.
I'm very happy that you mentioned how intervention can modulate immune response because, of course, you know that I'm going to make you the question on steroids. We have been using hydrocortisone mainly in the idea of the, we'd say, vascular effect or facilitating the response to vasopressor. But of course, I mean, hydrocortisone will have immune effect. Can you remind us, in the setting of everything that you were talking about, how steroids can interfere or modify or influence all the pathways that you mentioned?
We need to remind that cortisol, that the hypothalamic pituitary adrenal axis, together with the catecholaminergic axis and the vasopressinergic axis, constitute the main body response to stress, whether stress is induced by an infection, burn, trauma,
Yeah.
surgery. So for sure, these actors and cortisol, the endogenous cortisol, is a major regulator of the immune response and the metabolic response. And so, of course, what we still must acknowledge that the issue is we don't have adequate tools to say that in an individual patient that endogenous response is inappropriate also. Because if that response is inappropriate, then it becomes a treatable threat, it becomes a target for intervention, and more likely for giving exogenous corticosteroids. So not only that will help restoring the cardiovascular homeostasis, mainly by improving response to alpha agonists, vasopressin, angiotensin 2, and so on, also helping keeping the blood volume as normal as possible in spite of the increase in permeability. And there will also impact on the metabolism of the lactate. So there are important metabolic effects in the resistance to infection. And they also play a role in what we call the tolerance phase in inflammation. So it really is a drug, is a molecule that has a pleiotropic effect, is targeting all cells because all cells in the body has a receptor for glucocorticoid.
So my last question now, which is an already open one. Imagine that I hope we can repeat this podcast in 20 years. What do you think will be the changes in sepsis diagnosis management in 20 years? What is your vision?
Yeah, I think that in 20 years, we will no more see sepsis in the ICU, except sepsis acquired in the ICU, because we know that the majority of cases are starting in the primary care, and this is more and more recognized. And so I think that there will be a lot of investment in the upcoming years toward early recognition in primary care and intervention, secondary prevention, and also tertiary prevention to prevent those who had a sepsis episode to have another one in the year after. So I think that will be the main changes is no more sepsis in the ICU except those acquired in hospital in the ICU, and a shift of management toward prevention in the primary care.
Fantastic. Jalil, thanks for your great thoughts about this very difficult problem we face in the ICU about sepsis. I hope that everyone who will be listening to us will be happy and will enjoy what you tell us. And it will be my pleasure to see you in the next ISICEM podcast.
Thank you, Fabio. It was a very nice time to discuss with you.